Good afternoon, everybody. Welcome to our seminars in ageing, our regular seminar sessions. My name is Deborah O'Connor. I'm the Deputy Director at NARI, at the National Ageing Research Institute. I'm filling in for Bryony Dow today, who's in Japan at the IAGG, where no doubt some of your colleagues are as well. So welcome to our seminars. I'd like to begin by acknowledging the traditional owners of the land on which we are meeting today. For me, that's the Wurundjeri people of the Wurundjeri Woiwurrung people of the Kulin Nation. And I would also like to acknowledge the traditional owners of the lands and waters across Australia. I pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islanders peoples, including members of the Stolen Generation. Firstly, a little housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for some Q&A. If you have questions, you can submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of your screen. Today's seminar will be recorded and uploaded to our website within a few days. Please keep in mind, if you turn on your video to ask a question, your image will be recorded also be included in the recording, but please feel free to do so. So today it's my pleasure to introduce Professor Renuka Visvanathan, who's Professor of Geriatric Medicine at the University of Adelaide and was the project lead for the National Health and Medical Research Council of the Australian Centre for Research Excellence in Frailty and Ageing. She's also a geriatrician and head of unit at the Age and Extended Care Services at the Queen Elizabeth Hospital in Central Adelaide Local Health Network, South Australia. She was named as one of the inaugural Ageing 50 leaders transforming the world to be a better place to grow older. This was a United Nations Healthy Ageing Decade initiative. So we're very, very pleased to welcome you here. Today, Renuka will be presenting Tackling Frailty for Healthy Ageing. So welcome, Renuka, and over to you.
Okay, thank you very much, Deborah. So first and foremost, I'd like to thank the National Ageing Research Institute for giving me the opportunity to present here today. As per usual, yeah. So this just briefly, just conflict of interest, nothing really relating to the research that I'm presenting today. So this is the outline of my presentation for today. So I'm going to start off so basically I'm going to present today some of the research that we've done as part of our center over the last 7 or 8 years. So I'm going to firstly introduce the concept of frailty, describe how frailty is perceived by consumers, talk about quantifying and visualizing the frailty burden, emphasize today that frailty is treatable, and consider some interventions for frailty. So the first message that I always like to start with is to say that we shouldn't judge someone by just purely their age, because as people become older, the heterogeneity between individuals is more significant. So there's greater heterogeneity with increasing age, and some of this variability is explained by frailty. So the scenario I like to usually use to explain this phenomenon is, let's say we've got two patients, both of them the same gender, both 80, and both with the same condition here, which is a urinary tract infection. They both present to their GP. The first patient gets 5 days of antibiotics, they remain active at home, and they continue playing the golf they like. But patient 2 has a different cause. They get given 5 days of antibiotics, but they get delirious. They end up in hospital, they fall, they fracture their wrist, and then they go home requiring additional services. So here the difference between the two patients is their frailty status. So one's fit, patient 1's fit, patient 2 is a bit mildly frail. So what is frailty? Frailty essentially is a state of increased vulnerability to stressors. There is diminished homeostatic capacity across multiple physiological systems, and this can lead to poor health outcomes. This image here was created by Dr. Olga Teo, and we put it into a paper. The reference is below. And I think it's a nice way to illustrate what happens clinically. So here we've got two patients with a different condition this time. So patient one's fit, patient two is mildly frail. They have a stressor. So in this scenario, it is a fall. Patient one has a decline in function, but patient two has a greater decline in function. Patient one bounces back quite quickly and is back to baseline. Patient two, on the other hand, who's a bit more frail, takes longer to recover and very often doesn't get back to baseline. So this section here is an opportunity to intervene. So, so if we think about our current healthcare system, we are always trying to discharge patients soon. So they get discharged quickly, but if we don't spend some time focusing on this area, then we miss an opportunity to get people as close back to baseline as possible. So things like this period, we would like to look at things like restorative care, rehabilitation, things that can help people get back to their previous state of function. So when we were first funded with the CRE, or Center of Excellence, the term frailty was often used. And we got the sense that no one was actually talking about the same thing. So this was with consumers, they have different understandings. Clinicians, every clinician has a different understanding as to what they think frailty is. So we thought, okay, let's start off by trying to take a snapshot about the consumer's understanding about frailty. And at that point in time, we also thought that if the study gets repeated, let's say 10 years later, it'll be interesting to actually see if there's been a change in perceptions about frailty in our community. So we wanted to include varying degrees of frailty and people living across care settings. So this study included people who were living in the community as well as people who were living in nursing homes. There were 39 participants and there were 7 focus groups. This study was led by Dr. Mandy Archibald, who's now based at the University of Manitoba. So basically what was found, I'm sure Dr. Archibald can explain this better than me, but basically people had 2 views, I think 2 predominant views about frailty. One was that it was something that only afflicted older people, and it was a one-way trajectory to decline. It was usually experienced towards the end of life. And a lot of the people who had these perceptions always said, that's someone else, not me. So they could be frail themselves, but they would still say it's not something that I'm experiencing, it's something that someone else is experiencing. Another group of people described frailty as synonymous with disability. So they viewed it in the same way, but at least in this instance, they recognized that it might be dynamic, there could be improvement. Consumers viewed frailty as a loss of ability to do what they wanted and a loss of self-worth. But they identified that mental state, so the way people think and act, contributes to either in a protective manner or a facilitator towards either avoiding frailty or getting frailty. So we saw some things. One was the confusion that frailty was disability, and there appeared to be some missed opportunities for early identification. But importantly, also it was this negative connotation, so not wanting to be labeled with the condition. So we've known for a very long time now that frailty is not disability. So this Venn diagram is actually from Linda Fried's paper when she first proposed the phenotypic method for frailty. And so here we can see that people can either just be disabled only, or be frail only, or have comorbidity only, or have a combination of 2 things, or even for that matter, have a combination of all 3 things. But they are distinct conditions. So Linda Fried described what was the phenotype of frailty. So how would you recognize someone as being frail? She described 5 characteristics. So one was a feeling of fatigue, The other one was loss of strength. The next one was slowing, loss of muscle mass, and loss of activity. So frailty is said to be present when 3 of those 5 characteristics are present. Pre-frail or a risk state is there if only 1 or 2 characteristics are there, and fitness or non-frailty is when you had none of those 5 features. So one of the things that Dr. Archibald did was she developed quite a lot of videos in partnership with the consumers. So this was a way to actually debunk some of the misconceptions or misperceptions, and to try to raise awareness that frailty is reversible and something can be done about it. So if people want to take a look at the videos, you can go onto YouTube and look up Dr. Mandy Archibald. She's got her website has the repository of the videos, and they are freely available. All right, the next thing that we set out to do was clarify the disease burden. So we wanted to know how prevalent frailty was in our community. So the first study, and this study was led by Dr. Mark Thompson. So I put his image before that. So this was when Dr. Mark Thompson was a PhD candidate with us. He used the DINOPTA study, which was a study where the data from 4 longitudinal studies were harmonized. So we had the Northwest Adelaide Health Study. Oops, I went back. Yep, so the Northwest Adelaide Health Study, the Australian Longitudinal Study of Women's Health, AusDiab, and the Blue Mountains Eye Study. So what we found was frailty in these studies, the prevalence, so they were mostly community dwelling older people, so the prevalence was 21%, and pre-frailty or risk was 48%. We found that frailty prevalence was higher in female compared to men, and frailty prevalence increased with aging. So the thing about cohort studies is that very often it's a underestimation, because people who are homebound or in residential aged care who are more likely to be frail are usually not participants of this study. So this figures here, we just have to know that the real prevalence of frailty is actually higher. So the next thing we wanted to do is project what frailty prevalence might be like in the future, as well as maybe visualize the burden for the community. So Dr. Danielle Taylor, who's a health geographer, she applied the prevalence figures that from Dr. Mark Thompson's study to the Australian Bureau of Statistics census data for 2011 and 16, and then made projections for 2027. So based on those projections, it's estimated that there will be 609,306 older Australians living with frailty if we do nothing to intervene. So it's going to increase over time. I don't give the figures here are not there for the 2016 value, but the frailty prevalence will increase as the community ages, because we know that frailty prevalence increases with age. So Dr. Danielle Taylor next created a frailty web map, and this frailty web map is freely available. The link is up there. And so here we have a postcode of Woodville in South Australia, which is where the hospital I work at is. So this is the hospital. So what we can see here is that if we look at the map, we can see that there were 309 people with frailty, 309 people living with frailty in the postcode. And it's expected that that will increase to 398 by 2027 and 487 by 2032. So frailty prevalence in this postcode is estimated to increase by 33% by 2027 and 58% by 2032. So we need to recognize also that this is an estimate based on age and gender. So in actual fact, we wouldn't know exactly how many people are frail in the postcodes, but we can estimate that from just using the ABS data. Now, we also know that some organizations are using this map to plan for service delivery. So so it helps people target where services may need to go. So, but those cohort studies, a lot of the prevalence figures were from the early 2000s. So we wanted to see whether we could actually work out what the frailty prevalence might be for a more current time point. So we partnered with Wellbeing SA, which is a government agency here in South Australia, and this agency conducts population health survey module systems, which are omnibus type surveys. So we developed a survey with them where we put in some questions that align to the phenotypic criteria, and they surveyed almost 2,000 people aged 45 years and older. So here we see that the prevalence of frailty was 18.8% in those 75 years and older, 12.1% in those 65 to less than 75 years. But interestingly enough, frailty prevalence was there also in people 45 to less than 65 years. So this tells us that if we're going to do prevention programs, we need to actually start earlier. You know, no use waiting until older ages. We can actually start at a younger age. So the next part of our research was we were hearing from the aged care sector that they were actually dealing with frailty. You know, they were having to manage frailty in increasing numbers. So what we did was, together with Professor Maria Inakio and Dr. Katka from the Registry of Senior Australians, we developed a frailty index for the aged care assessment data that's collected. So as we know, frailty index at a minimum should consist of 30 items. So we created a 44-item frailty index consisting of 8 activity limitation items, 23 health condition items, 12 signs and symptoms. So these are questions from the ACAT assessment that's done nationally. So it's something that's nationally representative. And the frailty index that we developed behaved exactly like every other frailty index. The higher the frailty index score, the higher the risk of mortality. So we had an index that worked. So we then applied it to the aged care data. So the Registry of Senior Australian has a historical cohort. So we looked at the proportion of older people using home care packages. And then we looked at the frailty index score in the ACAT that was closest to when, before they started using, or when they were using the aged care assessment. So the time point that was the closest. And then we used a FI score of around 0.2, because we said, okay, if you've got a FI score of greater than 0.2, you're frail. So based on that, we found that with community home care package recipients, there was an increase in the proportion of people scoring more than 0.2 from 61.9% in 2006 to 88.4% in 2015. And then if you looked at people using residential aged care services, there was also an increase seen from 68.2 in 2006 to 87% in 2015. So we can say that the majority of people entering an approved aged care program in Australia are frail at the time of ACAT approval. So we wanted to then look at, just a snapshot of people living in residential aged care. Does the same thing hold true? So here in South Australia, we have a longitudinal study, which we've named the Frailty in Residential Sector Over Time study. We surveyed people in one aged care organization, residents in one aged care organization across 11 of their services in 2019. And then we repeated that assessment in 2020, and we've been following them up for around 3 years and linking their hospital data. So what we did in that study at baseline is we created a 60-item frailty index from all the questions that we administered to the residents. And based on that 60-item frailty index, we found that 95.3% of residents were frail in 2019. We were able to compare this to a previous study from 5 years earlier, which was smaller, but from the same organization and involving 6 of their facilities, and the frailty prevalence then was 85.2%. So we can see that the frailty prevalence in residential aged care is increasing. So we can conclude then that frailty is clearly core business for aged care. So coming back to the perception of the consumers, we heard from them that they didn't think that frailty was a reversible state. We also knew from some of our qualitative research with clinicians that similarly, they did not feel that frailty was something that was reversible. So people had this general feeling that basically, frailty was a one-way journey. Once you're frail, you just get worse and worse until you die. So we wanted to debunk that myth. So the first thing we did was we used the Northwest Adelaide Health Study again, and in that study we had people at baseline and then 4.5-year follow-up. And we looked at change in frailty status with the frailty phenotype criteria. And what we found was, in actual fact, without any intervention, 40% of people remained stable and 15.5% of people actually improved. So the reality is, without intervention, there were people improving. Perhaps with intervention, more people could improve. We next wanted to do the same for residential aged care. We felt that that was very important. So, but for residential aged care services, it's difficult to do the phenotype method. So again, the frailty index was the preferred method in the study. And then what we did was we wanted to firstly work out what was the minimally important difference for change in a frailty index score. So we did that using the distribution-based method and came up with this figure, 0.063. So then we applied that to the 2 time points that we had, 2019, 2020, and looked for change over time. And what we found was that 13.7% of residents improved. So the residents did get better. And 1/3 remained stable. So we think this is really a really important message. Sure, 1/5 of residents died in that 1-year period. So end of life care planning is important for some residents, but we also can say that there is the potential for others to improve with intervention. We know that Professor Maria Fiatorenising, for example, I think in the early 1990s, published that older people in residents of nursing home can actually undertake exercise of high quality and improve. So we need to focus on helping people in residential aged care improve when they can. So now that we're talking about exercise, I just wanted to shift towards to start again more at the front end and talk about some prevention, right? So we know that exercise is a good thing. And so this is a project that we've been working on over the last couple of years. And the way it all began was when Dr. Veera Verma here, a judo coach, approached me to talk to me about wanting to do some research to back an idea that she had that judo-like exercises might be beneficial for older people because it teaches older people to fall. And her idea was that by falling a bit more safely, then injuries could be prevented. And we know that it's a form of exercise, so it would also help with frailty. So Dr. Agatha Daria Jacek from our center has been working with Dr. Mira for some years now on this project. So I'll just play this short video where Agatha tells us about the project.
My research focuses on various strategies how we can prevent, treat, and delay frailty in older adults. My name is Dr. Agatha Daria Jacek. I am a postdoctoral research fellow at the University of Adelaide, Geriatrics Training and Research with Aged Care Centre. I am based at the DISABILITY Institute for Translational Health Research at the Queen Elizabeth Hospital. Frailty is an age-related syndrome that is characterized by decline in physical function and performance. Frailty places an older person at an increased risk of negative health outcomes. Some signs of frailty include slow walking speed, unintentional weight.
Oops, sorry. Technical hiccups. I'm trying to go backwards. Yes, we'll play
My
this.
research focuses on various strategies how we can prevent, treat, and delay frailty in older adults. My name is Dr. Agatha Darya-Yatsak. I am a postdoctoral research fellow at the University of Adelaide, Geriatrics Training and Research Research Center. I am based at the Visvanathan Institute for Translational Health Research at the Queen Elizabeth Hospital. Frailty is an age-related syndrome that is characterized by decline in physical function and performance. Frailty places an older person at an increased risk of negative health outcomes. Some signs of frailty include slow walking speed, unintentional weight loss, feeling weak and exhausted, and having low physical activity. When older people are frail, they are more likely to fall, end up in hospital, lose their independence, and have a lower quality of life. We know that over 50% of older people who are frail experience a fall each year. And with an aging population, this is a growing problem. But frailty is reversible. Exercise programs that include aerobic, strength, balance, and flexibility are actually the most effective way to treat, delay, and prevent frailty in older adults. One innovative aspect of our research is to use the sport of judo to help older people to be best prepared in case they do fall.
If we can teach people how to fall safely, they protect their head. Their hip just preserves people's quality of life and improves their capacity to do things.
It makes sense because if older people learn how to fall safely, they can avoid injury, not end up in hospital, or have other negative health consequences. In collaboration with the University of Adelaide Judo Club, we conducted an 8-week judo-based exercise study involving older adults aged between 66 and 87 years. We found that our program was safe and improved both physical performance and balance. Preferred participants, those who are at higher risk of becoming frail in the near future, were actually those that improved the most.
It's a compliment to what's going on in life. I mean, in terms of things like gardening and weeding, like I know it's helping to get down lower to do those sorts of things.
I'm able now to do the things that I want to do and to keep doing the things I was doing when I thought I might have to give them away.
We have published this research in the International Journal of Frailty and Aging. We are very happy to see that some of our study participants continued with the Judo Club and have now been graded the yellow belt in judo. This program is still being offered by the Adelaide University Judo Club with growing interest from the community. We don't want our population to just age. We want to find the best ways for them to age well, stay healthy, and remain independent.
So the purpose for showing that video is I think it's really, really a nice project, but also it just shows that we can make exercise fun and beneficial for all the people. And, the group activity is always good as well for health. So next, I want to talk about a collaboration that we've been undertaking with the Canadian Frailty Network. And I really like international collaborations because we get to learn from what they are doing. So the Canadian Frailty Network has come up with this public health or community-wide approach to preventing frailty. So they reviewed the literature, and then they had this extensive workshops with multiple stakeholders and came up with this acronym or a set of interventions that they felt would be beneficial in preventing frailty. So avoid, so A for activity, V for vaccination, O for optimizing medication, I for interaction, and D for diet. So, it's a nice acronym. If we can even just get everyone to do these 5 things, I'm sure health would be much better. And to facilitate the avoid intervention implementation, the Canadian Frailty Network has also developed a web-based technology platform that supports individualized coaching, disseminates educational information, and recommends curated community programs and services. So essentially, this website they make available in a local community, and people can register themselves, go in, complete a self-assessment. And in fact, the self-assessment tool for frailty on their website is the search tool that was developed by our group by Dr. Mark Thompson, which essentially scores into a frailty index. But it also gives us risk, like, if someone has problems with vision or hearing, or, you know, nutrition, it actually comes up with a checklist like these are the issues that were wrong with you. And in this website, there are lots of educational material, so the person can actually educate themselves about what the issue is, how they might improve themselves. They're able to set goals, and receive coaching if they would so like through the intervention. And finally, there's like a map. So what they've done is they've collected all the services in the region. And so let's say I was looking for an exercise program and Tai Chi takes my fancy, then the map actually shows where you might be able to go to join a Tai Chi class. So this is the intervention that they've had. I think of a couple of weeks ago, they told me that there were around 389 people registered in Kingston alone. They're going to roll it out across 3 other cities in Canada. So it'll be very fascinating in a couple of years to see what we find from this research that's going on in Canada. So comprehensive geriatric assessment is an intervention for frailty. We've long heard about comprehensive geriatric assessment. If we did it properly, it would involve a multidimensional comprehensive assessment. It would then result in a management plan. Ideally, it should involve the multidisciplinary team. Then goals of care should be established together with the patient and their family, and then the treatment done. And very importantly, often this is then the missed part of the comprehensive geriatric assessment. There should always be regular review to review the patient's progress against the goals that have been established. And if necessary, the management plan appropriately refined. And then the cycle should continue. So back to the beginning, for a comprehensive assessment, and we repeat with the aim of getting the person to improve over time. So we've recently completed an umbrella review, which looked at 10 meta-analyses. And basically, comprehensive geriatric assessment helps older people remain at home longer. So in the past, we've presented that it is possible for comprehensive geriatric assessment to be completed in general practice. There are Medicare subsidies which GPs can claim, which when you put them together, reflects a comprehensive geriatric assessment. So you've got the 75+ health assessment, which is available to people 75 years and over. It can be done annually, followed by a management plan and a team care arrangement. Together, when they're done, referrals, there can be a referral to the allied health services. So a patient will then be entitled to at least 5 allied health activities. Often, currently, in the majority, people use it for podiatry. A GP can initiate a home medication review, and in that scenario, the patient would be able to see a pharmacist. If there's concerns about mental health, they could do a mental health plan, and that would result in a clinical psychology review. At all times, if someone needs it, patient can be referred to My Aged Care for access to the CHSP or home care package. And through that also, patients can gain access to other team members. So, and then there's an item for review and the cycle can continue. So this is possible. So the next question we had is it being done? Well, we couldn't look at everything, but what we did was we used the Registry of Senior Australians again to look at the home care package recipients. And we looked at home care package recipients between 2011 and 2015. And we looked at the 6-month period around the ACAT. So the 6 months before and the 6 months after. And we asked how many people were getting any of these item numbers in that period. So we found that less than a third were getting health assessments. A little bit more than a third were getting the management plan and team care arrangements. These are usually a bit more popular because you get the 5 allied health services. And then medication review, even though we know that medication misadventure is a very serious problem, home medication reviews are hardly done. So we didn't even look at this in sequence. So if we look for these 2 things, these three things being done in combination, again, the proportion is very low. And at the start of this presentation, I already highlighted that a lot of aged care recipients are frail, and surely we should be hoping that many more of them, the proportion should be much, much, much higher. So there's an opportunity here. So the next thing I want to talk about is some of our work with in Malaysia, with Malaysian general practice. So here we got Dr. Teo, and I have to credit her with kind of motivating us to undertake this project. This is Dr. Sally Ahib, who's a family medicine physician in Malaysia, who's been leading the majority of work over there. So this research began with Dr. Teo telling us about this new tool that she and Professor Ken Rockwood had developed out of Canada to support comprehensive geriatric assessment. So it's a multi-dimensional tool made out of pictures. This is the Malay version. So if you're thinking some of these words sound alien, it's because it's in the Malaysian language. But of course, the tool that was developed by Professor Rockwood and Dr. Teo was actually in English. So it covers off on the domains of mood, number of medications, mobility, function, balance, social connections, memory and thinking, vision, hearing, pain, unintentional weight loss, aggression, and bladder control. If you want to access the tool, it's available on the Dalhousie University website. So we thought that this tool might have some use in Malaysia, especially with people who have low educational background, because the pictorial nature of the tool makes it more useful in those settings. So what we wanted to do, because this would be the first time that the tool was actually being investigated outside of Canada, and that too in a primary care setting, because it had previously been tested in specialist geriatric services, but not really in primary healthcare setting. So we wanted to know about its inter-rater reliability, test-retest reliability. And so what Dr. Sally Ahib did was actually conduct a study in 4 publicly funded primary care clinics in Malaysia, 2 in cities, 2 in rural areas, and to just make it comprehensive across both parts of Malaysia. So in this part, as well as in the state of Sarawak. So in Malaysia, the Ministry of Health actually funds public primary care clinics. They see patients of all ages, and in a day in the city clinics, you could have nearly 500 patients coming to these clinics each day. They manage maternal and child health as well as chronic diseases. So 240 older patients, 60 years and older, coming to the clinics were invited to participate in the study, and they had to have carers. So also the carers were invited to participate. So the patients completed the pictorial fit frail scale, and so did their carers. And then the patients were assigned to either a nurse or allied health assistant, and then they would undergo 2 assessments by the same clinician to test inter-rater reliability, not same clinician, but same clinician type. And then all patients had an assessment by a doctor on that day also. So you could test inter-rater reliability there too. And then the patient was assessed by a research doctor with a frailty index, which was the search tool. And so that was for convergent validity testing. And then all patients returned after 1 week for assessment by either the nurse or allied health practitioner, depending on who they saw at the first visit, and the doctor, so that we could test and retest reliability. And so what we found was that the interclass correlation, as well as the retest reliability, was excellent for the pictorial fit frail scale. And then we looked at the convergent validity and was moderate. And then what we did was also develop cutoff scores for the pictorial fit frail scale Malay version against the frailty index. So these were the cutoff scores that were developed. We then looked at predictive validity. There was an 18-month follow-up to the cohort. There was significant dropout. So this sample size was quite small. We had to use a composite outcome of mortality, disability, hospitalization, falls, and nursing home placement because of the small sample size. And we need to be mindful that those that dropped out were probably frailer and also sicker. So, but after adjusting for age and gender, we found that the tool could predict poor outcomes, both for people with frailty as well as people at risk of frailty. So it's no use just picking people at risk and then telling them that they've got a problem and then telling them that this is going to make them at risk of bad outcomes. You need to do something about it. So Dr. Sally Ahib managed to establish the first publicly funded specialist primary care geriatric clinic in the place that she worked. So now the model of care there is, you have all the older people who come to the routine clinics. If the doctors seeing them there feel that they are frail, usually their clinical frailty score is 4 or higher, then they get referred to Dr. Sally Ahib's specialist geriatric community clinic, where she uses the pictorial fit frail scale as a comprehensive geriatric assessment. She then does the PFFSS again at 3 and 6 months as a method of reviewing, refining, and reassessing. So what do they do there? Like after the comprehensive geriatric assessment, then people are streamed into interventions that might suit them. So the interventions delivered in this clinic include exercise, nutrition, cognitive stimulation. They encourage a lot of group activities, so interaction, medication review, and illness optimization. They've had some good outcomes from the clinic, and as a result of that, the Ministry of Health in the state of Sarawak has in this year begun the process of rolling out this clinic across the whole state. So that's a good example of good translational research. So I now end here by just acknowledging that a lot of the research that I've presented today had significant support from many funding bodies. Without their support, we would not have been able to do the research. And of course, along the way, I've highlighted some of the team members that have been involved in this research, but that's not at all exhaustive. So there are many more that I've missed in putting up their faces. Thank you.
Thank you very much, Renuka. I think there was a lot of information in there for people to digest and think about, but we've got a number of questions that have come through the chat. And if anyone else would like to ask a question, if you'd like to raise your hand, and I'll try and find you on the screen as well. My first questions on the chat was from Alexander. There was also some effusive comments too, commenting on what a wonderful presentation. But Alexandra Lekis asked, if somebody is identified as frail or pre-frail, how long after the intervention and the beginning of a management plan is there likely to be measurable change, and how much time is recommended before reassessment?
Yeah, so I think there's no fixed and absolute value to like when we should reassess. I think if someone is quite fragile, that means their health is not stable, then I would recommend seeing them sooner for a review to make sure that they are on the right trend. So in that scenario, I would see someone at 6 weeks. But I think otherwise, in a more chronic population, you can expect to at least see some change in terms of process. Like, so, so if you've asked them to exercise, you might be able to pick up some changes to their gait speed. I think by the 3-month mark, you definitely can pick up change in their behavior at the 3-month mark. So, and then most likely by 6 months, you should start to see some change. So if you asked me how often I would see a patient, I think if they're very stable and chronic, as a specialist, I would see them at baseline 6 months and 12 months. If they've just been recently unwell, I would tend to see them at baseline 3 months and 6 months. But if they're more unwell and unstable, I'd see them more frequently. Because during your reviews, not only are you looking for change in outcomes, but you're actually also looking for change in their behavior. So are they actually adhering to their goals, the goals that they set with you, and whether there's a change in, and if they're not, why that might be the case. And if they're improving even better, you might actually want to set new goals because they're doing so well. So that's my suggestion.
Thank you. The second question here from Joyce's farm. Have there been any studies with First Nations people in rural and remote Australia? The pictorial, this talk looks like it would be great to use in remote communities where there are multiple languages. Yep.
So in terms of the pictorial, I'm assuming that this question is directed to the use of the pictorial fit frail scale with First Nations people. Yes. And yes. No, it has not been studied yet. And so there's an opportunity for research in that way. And I'm sure Dr. Theo would love to hear from anyone interested in doing such research.
Thank you. David Wang asks, what is the DALI or DALIs or YLLs from this PFF study?
So we didn't look at that, so I wouldn't be able to answer that question, unfortunately. Okay. And also, it was a small sample size. A lot of people were lost to follow up. In the study in Malaysia, it relied on the research officer ringing for people and for them to answer. So if they changed their address, they moved, or they lost their phone numbers, they would be lost to follow up. So it wasn't using the death registry. So that made that those were limitations to that study. COVID didn't help either.
Imagine. Okay, thank you. I have a question from Rashid Mark, who says the 40-item FI application practice such as busy ED or patient critical challenging identification or screening is first crucial point in practical life. What would your suggestions be regarding this?
Okay, so this is like very much to a long time ago when I first started my PhD, we used to have the same questions for nutritional screening. So ultimately the choice will be based on clinician preference. So, you know, in different settings, they'll come up with their preferred way. So I don't think there's one fixed item. So when it comes to the frailty index, I'm not recommending the use of frailty index, but I think with computer system automation, where places have automated scoring systems, then it will be possible for an instantaneous generation of a frailty index. But for many places, we're a long way off from having such a tool. So there are many screening tools. So the clinical frailty scale is one of the most popular tools. It's also pictorial. The only word of caution is some people think, oh yes, it's really quick to do the clinical frailty scale because I'll just look at the pictures and decide on the frailty level. Well, when it was first designed, it was actually developed to follow on after you've done a comprehensive assessment. So it's not supposed to be done just like that. So Professor Rockwood has recently published an algorithm to guide the completion of a clinical frailty scale, and I would recommend doing that. There are other tools such as the self-report Edmonton frailty scale, the frail NH, the frail scale. So they'll all have their pros and cons. They'll have variable positive predictive values, negative predictive values, but compared to doing nothing, any of the tools would be better, because I think in some clinical practices currently, you'll come across clinicians saying, I can sniff frailty, I can just smell it, I can see it when I see it. I think I would say that that's usually when it's a bit late. So I think when frailty is there and it's obvious, we'll all see it. But the whole idea is you want to pick it earlier and do something earlier, make a difference earlier, and then measure for that change.
Thank you. So, Judy Ocean, it's a fabulous presentation. This research program. Andrew Demopoulos, patients on follow-up showed, I think, 50% improved and 30% stayed the same. Was there any drilling down as to why this was the case, or do you have any explanations?
Very good question, Andrew, but the reasons skip my mind currently. The primary paper, the paper actually has those reasons. I think some of it related to better management of chronic diseases. So, factors associated with improvement or worsening were identified in that paper. And management of chronic diseases is an important variable.
Thank you. And David Wayne responded, thanks, Dr. Renuka. That's understandable. Excellent study, lots to learn from. A question from Catherine Lee. Thank you. So fantastic to hear about such international initiatives to prevent and treat frailty. Do you know if such persons identified as frail in the Malaysian program have ongoing access and uptake of exercise programs intervention, and how this is funded? Challenges I find as a geriatrician in Melbourne is the lack of motivation of patients to undertake a home exercise program and capacity for ongoing physiotherapy.
So that I think is a universal problem across the world, funding. So the study that the clinic process that I presented, the program is not long. It's not for a long time, but it's, if it's for 3 or 6 months, and it's through the publicly funded clinic. But as you can tell, it's a small number of patients that can access that program. So I think everyone else has to pay for private physio, which can be a barrier. And so it's work in progress, I guess. But things have to start somewhere. And getting people to be motivated to exercise. I think that's where this empowering people through education and knowledge has to be important. I mean, patients often come to see me as a doctor and they want a magic cure, a pill, a medication. And I think the barrier to exercise is because the patient has to do it, right? It's not as easy as swallowing a pill. But I think it's coming to that understanding that some of these things, once they're a bit more aware that these things make a big difference for their health, I think a lot of people would actually change. And it's about changing their mindset earlier, which I think is why I presented the judo program, because I think that's really nice. It's something that, we're targeting people in their 40s to 60s or 70s. And if they get used to doing exercises earlier, then they're more likely to keep doing it in older age, as opposed to trying to introduce it for the first time in older age. That's harder.
Thank you. There's some more questions coming through and some more congratulations. The next one is in the vein of the previous question from Julie Dundon. Thanks, Renuka, for a great presentation. What challenges and how can they be overcome for access to allied health services, particularly dietitians and physios? I think you partially answered that.
I know, Julie, usually you'd ask that question. So I think all we can do is raise awareness, right? So one is to the community directly. If they feel it's important, they will pay for it, I think. Those who can afford it. Then the other is raising awareness with government with the hope that government will make avenues available. If they can see the benefit that these things prevent downstream consequences, then I think things will become a bit more available, but it's going to take some time. I don't think it'll happen overnight, but hopefully by continuously reinforcing the messages to everyone, then maybe those changes will come slowly but surely.
Yes, I was thinking it's very much profile raising too in the community, isn't it? I mean,
yeah.
Dementia has managed to really break through, I think, in the last few years. And so frailty is probably less recognised. Individual components of falling over or breakage as a whole.
Yeah, in fact, when we started our center, the first thing we said was we feel like as though this is just like the dementia story, but maybe 10 years ago, like so frailty is like 10 or 12 years behind the dementia movement.
I just have a question around the family's engagement or, a close person. I just wonder how important it is to engage them to build confidence in them, as well as the the individual around some of those prevention activities.
Yeah, so I think involving the carer is very important for two reasons, right? So one is you're educating them for themselves anyway, and we know that carers sometimes let their health suffer while prioritizing their family member. So you get two for the price of one. You can improve their health as well as the person they're caring for. The next thing is there are some patients who need. They themselves won't remember to exercise or are not able to get to their exercise programs. And only when the carer understands how important something is, then they're more likely to be able to participate and be unable to participate in it. So I think involving family is key to helping motivate the individual to do something. So, so it's like a team effort, but you get two for the price of one, because if the team member changes their behavior, then.
And reducing fear too. I was also thinking there's very strong health economic arguments to be made on that public profile. And there's questions and comments pouring in at the moment, thanking you, and quoting Robert Butler about exercise could be and heading into exercise being Lynette Hoffman must be in hospital first and have an ACAT assessment to qualify for the Allied Health Program. That's care. Also new throughout the program. And then very interesting work and from Vicky Abertins. I think there's a huge amount of interest in your topic, Renuka. Probably got some more questions out there. I know I could put a number, but I think we're running out of time, so I probably should wrap up at this point. And thank you very much for your presentation, and ask everybody to share their clap reaction.
And I want to thank the audience for being such a captive audience and being here with us today. Thank you.
Thanks. And I would just, before everybody goes, just a plug for next month. Associate Professor Karen Pike will be presenting Increasing Older Adults Access to Memory Interventions, the online personalised training in memory strategies for everyday, in brackets, optimised program. So please join us next month on the 11th of July at 12 o'clock. And thank you for attending. And you'll be prompted about in the future. And if you'd like to do an mailing list, please contact Nari as well. Further information. So thank you, everybody, and have a good Tuesday.